evening, everybody, and welcome to another edition of Worldwide WiSH, our first international meeting of the year, presented by WITS Sport and Health, or WiSH as the acronym stands for. And a very warm welcome to our panelists and also to our attendees this evening from all over the world. So we welcome you. This particular session is hosted by the Sport Concussion Interest Group. What we normally do in these interest group meetings 3 or 4 times a year is we have a presentation on an interesting topic which we discuss, and we also look at 1 or 2 papers. And today we're going to be able to roll that all into one with 2 very distinguished international speakers. But before we do that, a big thank you to our sponsors, Ascena Lita Pharmaceutical Group, manufacturers of Zepho, who very kindly sponsor the Zoom setup for these meetings. We're very grateful to them. And you will see their advertisements on our slides and also on the slides that precede this presentation. So thank you very much to them. Thank you also to Dr. Robin Saggers for being in the background and managing all the technical aspects of this talk. All the promotional material you receive comes through him. And so we thank him as a very valuable member of the WiSH Management Committee for assisting us. So I'm going to ask Robin just to put up a slide to introduce this talk as we start, to share a slide which he's got. And as I mentioned, we like to invite some speakers who share very useful information around sports concussion. And we also like to discuss some papers. And we're very, very fortunate in having timed this meeting, which we actually set up last year, as the paper that you see featured here on this slide was actually published online about a week ago. And accompanying it was this press release. And it's not often that scientific papers come with a press release, but such is the potential significance of this research that it was deemed necessary to actually publish this research in the lay press as well. And those of you that work in the field of sports concussion know that one of our big challenges is objective diagnosis and monitoring of this very difficult condition. And so imagine if we had a marker that told us definitively if someone was concussed, and that we could use to monitor the severity and potentially the recovery as well. And research has been moving in this direction for some time. And leaders in this field have been a team from the University of Birmingham, working with a company called Marker Diagnostics to develop various biomarkers, which we're going to hear about, that in particular a salivary biomarker. And why that's significant is because it is really not invasive at all and very easy to do once you've evolved the technology. So I'm not going to steal our speaker's thunder, but this is an open access article. So go to the BJSM website, British Journal of Sports Medicine, and find the paper. I think we did circulate it on our WhatsApp group. So you should be able to access it there as well. But it's open access and definitely worth a read, especially after you've listened to this evening's talks. So Robin, you can take that off as I introduce our speakers this evening. And the first person to join us is Professor Tony Belli. Professor Belli is an academic neurosurgeon at the University of Birmingham and Queen Elizabeth Hospital in Birmingham. This is part of the University Hospitals of Birmingham NHS Trust. He's a director of the National Institute of Health Research, Surgical Reconstruction and Microbiology Research Center. This is one of the largest trauma research centers in the world. The NIHR SRMRC is jointly funded by the UK Department of Health and the Ministry of Defence. And Professor Belli is renowned for leading numerous multi-center trials and observational studies in traumatic brain injury. And he's the chief investigator of the ongoing Repetitive Concussion in Sport, or RECOS study, which is one of the largest research programs on concussion in Europe. He's also an independent advisor on concussion to the Rugby Football Union and the Football Association, and he's co-authored the concussion management guidelines for England rugby and football, Great British basketball, and other sports. And he is the senior author of the study of concussion in rugby union, through microRNAs, or SCRUM, Salivary Biomarkers of Concussion. So we're delighted to have Professor Belli, and we're going to hear from him shortly. And joining him is Dr. Patrick O'Halloran, who's Registrar, Training in Sport and Exercise Medicine in the West Midlands. He's recently completed his PhD, so an academic clinician, and he's done his PhD in the field of salivary biomarkers of sport-related concussion. And he's continuing his work in this area as a research scientist with Marker Health. He currently provides medical support to the Worcester Warriors rugby team and the England women's age group rugby union sides. So really two very distinguished clinicians and speakers that we have joining us who are at the forefront of this research internationally. And one other reason, just to contextualize it, that this is important is together with Marker Health, Wits University and WiSH in particular is going to be leading a study, an extension of this study, looking at these biomarkers in youth sport. So we'll be taking this research and applying it in the youth sport scenario across both boys and girls. And we hope over the next 2 years to contribute from a South African perspective to this research. And we value Dr. O'Halloran and Professor Belli's support in this regard as well. So I'm going to hand over to the two of them to discuss the SCRUM study, which is a large collaborative piece of research investigating these novel biomarkers in concussion. And they're going to set the scene for us and then talk more specifically about these biomarkers in an area, as I say, of very, very exciting research. So I'm going to hand over to Professor Belli to share his screen and to take us from here. Welcome, gentlemen, and thank you.
All right. So good evening, everyone, and many thanks to the organizer for the invitation to speak today, and obviously to John in particular for the privilege of speaking to so many people who have share an interest in this topic. Because obviously, well, we're probably very fortunate at this moment in time to be working in this area because there's a lot of interest from different parts of the world in the topic of sport concussion. I mean, concussion in general, but particularly in sport concussion. And obviously, it's a great honor to speak to all of you because obviously I know this is it's an important meeting that it's actually it's international. So I know whether to say good evening, good morning, good night to many of you. So the way we have actually decided to run this talk is actually we're gonna do a double act with Patrick who's gonna follow my talk, and then first I just and obviously you all have an interest in concussion, so but I'm just going to introduce the topic of sport concussion generically, but gradually funnel down to the reason why we've come to the study, and what for us was really what were the priorities for getting the show on the road with this type of research. So so I'm just going to start sharing my presentation now, and this is so as Professor Patricios said, actually the study came out in press last week. There was a long embargo prior to this because of the press release, but you are the first group to actually listen. This is the first time we've actually presented it to an audience. So any comments, criticism, whatever you got, I think it's be really useful for us to hear it. And to say the first time we've actually presented it to a scientific audience. So really the first concept that I really like to introduce is that traumatic brain injury. Obviously, I work in the field of neurotrauma. So I'm a practicing neurosurgeon, and I think this is I'm one of the very few neurosurgeons you'll ever meet who actually has got an interest in trauma. Most of my colleagues run a mile when they hear trauma, but for a number of reasons. But actually, I like trauma. I've always liked trauma, and I think it's a really important topic because it is the leading cause of death and disability in young people. It accounts for sort of about a quarter of all trauma. But in the UK, for example, there are 1.4 million people that attend the emergency department, every year with some form of head injury, and it's disproportionate cause of death and disability in all causes of trauma. And as I said, particularly in young group. what is actually tragic in a way, the vast majority of the burden is shouldered by low to middle income countries. And increasingly, we're doing work with a number of countries around the world, because there's a lot that we can learn from other people's experiences, a lot we can share with other countries as well. But it clearly is not just that, sort of confined to one geographical entity or another. It's just as a problem that we all face. And it's probably, often concussion is used, mutually with the term mild traumatic brain injury. And actually, for all of us working in this field, we know that there's nothing mild about head injury in general. This is a Glasgow study, which is now probably a little bit dated, but bearing in mind these are hospitalized head injury admissions. I think what we know from that study that was done, well, it's probably done about 20 years ago now, but they actually, even the mild group, actually a year down the line, there were about 8% of people that were actually dead in this Glasgow group from people admitted to hospital following a mild traumatic brain injury. So not something you would call mild if it has a nearly 10% mortality rate, and only about half the people in the study after a year achieved a good outcome. So there's nothing mild about TBI in general. Obviously, sport concussion is seen as something slightly different from that, in that people don't get hospitalized. And the Glasgow study was considered a bit of an outlier, because people thought, well, people in Glasgow are a little bit less healthy than the rest of the UK or other parts of the world. But actually, the studies have been replicated by other countries and other cities and whatever, and the results are remarkably similar. So just something probably just to frame immediately is that mild TBI is not really that mild. But what is really, in a way, what is alarming about TBI in general, it is an increase in pathology. It is projected to become the third largest cause of burden of disease. Well, last year, we don't have the figures yet. But within that, obviously, sport is something that is a bit of a concern in itself. So sport is seen as something that is milder than the TBIs that get admitted to hospital. But what is alarming, that is also increasing. And actually, if you look at the figures, it's one of the few pathologies that's actually going up in incidence year on year. And sport concussion is reported to be increasing about 6-7% every year. It's also not just a problem in sport, it's a problem in the military as well. And part of these increasing numbers have been driven by perhaps better awareness of the problem. So it's not all negatives, and people are now more inclined to report a concussion than they were years ago. and it's certainly, all of that's been driven by, perhaps the awareness in the media, the campaigns, and possibly by litigation as well. There've been high-profile cases, particularly in North America. The most famous being the lawsuit against the NFL. Well, actually, it's still an open-ended award, but it's obviously it was brought by retired American football players. That actually, the problem that they had is not that the American football is dangerous. Everybody knew that, but it's more than the NFL had evidence of the damage and did nothing to mitigate that. And I say in the military, it's still a problem, although we know sort of many countries, in particularly US and the UK, are not currently in conflicts. I think there's still a number of head injuries that happen by soldiers. Obviously, they're young and fit, and they have very similar problems to what athletes experience. And also has been glorified in part also by Hollywood. And I don't know, many of you have actually seen the film Concussion with Will Smith, who plays the part of Bennett and Malley, who's the pathologist that's first reported CT in retired American football players, and the lawsuits and the events that follows. That was obviously been portrayed in a Hollywood film. So that seems to be that, as I say, there's increasing awareness, which is a good thing. But many people also say that actually sport is becoming more physical. There's more evidence, there's more emphasis on physicality. And that means that, collisions are getting bigger. Players are bigger, they're faster, collisions, and players spend more time in the gym. And increasing awareness hasn't necessarily resulted in incidents being being reduced. This is just a very notable example. So from just a couple of seasons ago, this is Vertonghen that was playing for Tottenham, and he was taken off the pitch to be assessed for a possible head injury. Very quick assessment. This is a quarter-final of a Champions League, a very, very big event. And he was allowed to return to play very quick. And a few minutes later, he had to be, helped off the pitch, with the official reports being that he just fainted due to some unknown reason. Except that a year later, then came out saying yes, he was concussed, and he, clearly that wasn't there. He admitted that a concussion had actually occurred. But what are the concerns about concussion? Well, first, for many people, including Patrick, who sits on the sideline in a dugout watching events, is the early damage is what most club doctors are preoccupied with. Just trying to mitigate, the early damage that happens with concussion and keeping players safe. But we're also concerned about other things, and these are not necessarily, the same thing. Certainly they are related somehow, but they're not exactly the same thing. So probably the other issue that we worry about is the second impact syndrome, and then the all kind of worms of neurodegeneration, which is much talked about in the media these days. So this group obviously probably needs very little explanation of the type of damage that might occur. For example, the direct impacts with with damage to the brain caused by shock waves propagating through the brain, coup contra coup, and particularly rotational forces, which are probably the most dangerous of the mechanisms of concussion. So effectively the straining of axons that happens during a rotational momentum. So serious injuries in sports, I think, it talks about the risk of death, but fortunately serious injuries in sports are rare if you consider the number of events that take place every week and every weekend. So the big injuries are the catastrophic injuries, luckily rare, but obviously they're not non-existent. And then obviously the doctors on the bench, sort of there to avoid bigger problems for players. Obviously this applies to professional sports, not necessarily to community sports, but catastrophic injuries are considered rare. But on many levels, we really need to understand what happens in the ordinary concussions that happen sort of weekly in an event. And to a large extent, we actually really don't understand entirely what happens in concussion. But we pretty much understand this is very much an axonal event, an axonal injury, and perhaps on a very simple level, what happens is the passive straining of axons just produces a release of neurotransmitters. So effectively, if you just strain an axon, if you just stretch it, the membrane will become more porous and neurotransmitters. So there's an ionic imbalance across the membrane, and then there's a release of neurotransmitters, and then what might cause the brief impairment of consciousness, not loss of consciousness necessarily, the transit amnesia, sometimes just for a few seconds, the patient falling over, stumbling, losing coordination for a few seconds, or losing muscle tone. And this is probably just, this kind of a very brief chemical imbalance that happens. But this obviously on a very simple level, what happens probably in the majority of concussions. But certainly if you carry on stretching and straining the axon, then what you get is damage to the cytoskeleton, so particularly the microtubules. The microtubules are effectively cabling that runs inside cells that connects the cell body to the synaptic end, that allow the transmission of vesicles, mitochondria up and down the axon, actually keep the axon going effectively. So if you strain an axon, eventually the microtubules will be damaged or will rupture. And this is an example of what happens. So if you get intact microtubules, there's quite a lot of traffic up and down an axon, but once you've actually strained it, everything grinds to a halt. The microtubules are damaged, so the traffic up and down the axon cannot take place anymore. And if you also carry on straining, sorry, my voice is a bit low today, straining an axon, what happens if there's the fasteners that keep the tubules together? It's actually it's tau protein, and you'll probably be hearing a little bit more tau later on. So tau protein is an intracellular protein that does many things, but one of the things is that is to keep the microtubules fastened together. So once you get this damage to the microtubules, you get a release of tau protein. And tau protein works a little bit like a prion disease. So it will catalyze the aggregation of more tau protein, and it will form microcomplexes of tau protein that eventually will cause an inflammatory response. And that inflammatory response, it tries to remove the aggregate, then eventually will cause damage to the neurons themselves, a bit like prion disease. And this is one of the mechanisms that is postulated in chronic traumatic encephalopathy. Is there any evidence of this? Well, we're gathering evidence of this, and this is accumulating. And I'm going to show something else about tau later on, but this is a slide from a study done at Imperial College that actually, even following sort of single mild traumatic brain injury, you can actually detect signs of neuroinflammation for many, many years. In this study, it was 16 years after the initial event, and actually there are regions of the brain that accumulated sort of in a way, but neuroinflammatory biomarkers that never really seem to go away. Obviously, they don't cause necessarily active inflammation, but they're there dormant, and they're there to be activated if you have another trauma. So this leads on to, what happens in the second impact syndrome, which is something that obviously, fortunately, very rare because it's actually seriously bad. And is more common in children and adolescents. And this is a picture of a very sad case of, sort of a young rugby player in Northern Ireland called Ben Robinson, who suffers 2 concussions in the first half of the game. He was assessed. He said he was fine. The doctors thought he was fine. He was allowed to return, but he suffered a 3rd concussion in the second half and never really woke up. So he died. He died shortly after that. So what happens if the brain gets injured more than once? Well, it can develop, catastrophic edema. So brain swelling, which is actually what you would see in a big road traffic accident. What happens in a high-speed road traffic accident, and we still don't understand the mechanisms of that, but we've done some studies of that. Actually, we in our studies seem to be related to mitochondrial impairment, so the mitochondria becoming impaired and shutting down, and when the second event, if the second blow hits, the brain is ill-equipped to deal with the second impact, and it begins to swell up. And it's primarily children, it's primarily young adults that suffer from the syndrome. But so this is probably why we have different guidance. One of the reasons why we have different guidance for young adults compared to the more grown-up players. But obviously there are other reasons as well. So in a study that we did in animals, we worked out if the brain was injured. This is in rats, of course. But if the brain was injured at the wrong time, the effects on the brain was similar to what you would see in a severe impact. So what you would see in a road traffic accident, effectively, just by getting the timing wrong. So and obviously, if you get injured very quickly after the first injury, it's bad. There is a particular timing when the brain is most vulnerable, except this in humans, it's very hard to study. It's very hard to know when the brain is most vulnerable. We thought we could get a handle of that by looking at MR spectroscopy, for example, looking at a particular compound called N-acetyl aspartate, which is an indirect marker of mitochondrial function. And actually, when we did the study in professional footballers, we could look at NAA concentrations. In those days, it wasn't difficult to get people that would get a second impact. And these days, this is something that you should never see. So it's actually, it would be impossible to recruit the studies now, but it was done about more than 10 years ago. So players that got hit more than once, professional football players in Italy, we could detect, sort of that the NAA levels will return back to normal over a much longer period of time than people that had just a single concussion. We still do a mass spectroscopy in our clinic. So probably one of the most talked about issues is that of what happens in the long term to people that suffer, sort of a number of concussions. And this is it's a very big topic, and it's very controversial still. And also there's a lot that really we don't understand about chronic traumatic encephalopathy, long-term neurodegeneration that happens after traumatic brain injury. We know that CT is effectively a tauopathy, so tau comes back. There's an accumulation of tau in certain regions of the brain, and it's particularly evident in certainly hinge points where mechanically you would expect most of the strain to happen. So you see tau staining when you look at the brain under a microscope. Now, there is a distinction to be made. The fact that you see tau under the microscope doesn't mean that necessarily is you're looking at someone who's got a progressive, invariably fatal neurodegenerative condition. You can have tau staining in people that never display symptoms of CT in life. But clearly what CT is about is an accumulation of tau. As I say, this works very similar to chronic traumatic encephalopathy. But there are now sort of a number of cases that have been reported, particularly in North America, and particularly by the Boston Brain Bank. It actually reported a number of retired athletes, primarily from American football, but some military, some from other sports as well, whose brain was examined under the microscope, and the vast majority, just all of them effectively that were looked under the microscope, there's some evidence of CT, of possibly tauopathy. And there is evidence of some studies report more cognitive problems in retired football players. There's also some interesting research that's come from animal studies, where if you injure mice with a mild-TBI, they do seem to develop a tauopathy. And also what is interesting, the tauopathy then spreads through the brain. But if you take brain from an animal that's got tauopathy and you put it into the brain of a healthy mouse, the healthy mouse develops a tauopathy as well. So it does actually very much remind us of what happens in Prion's disease, in the mad cow disease. This is really interesting evidence. But there is a counterbalance, and actually not everybody's convinced that this is the case. And obviously, if you look at the number of people that play sports, and I mean, there's millions of people that play sports around the world, billions of people that play sport around the world, the epidemiologic evidence is still very, very limited. There's still very few cases have been examined in relation to the number of potential cases. And actually, there is possibly some selection bias. Obviously, the people that donate the brain, for the vast majority, people that have antemortem problems with, particularly with cognitive behavioral problems. So you're more likely to see evidence of some kind of neurodegenerative condition in those brains. Also, other factors need to be looked at. I mean, the fact that people have retired from American football or soccer or other sports doesn't, means that probably, when you compare to controls, there are a number of things you need to adjust for. So maybe there's more than one difference between, somebody who does professional sports and somebody who's like you and probably many people in the audience that can do professional sports, and to do with lifestyle, premorbid factors, potential drugs use, performance enhancing drugs. Weight is one of those. I mean, people that I don't want to digress too much, but some people suggest that once you control for example, sleep apnea or other factors in retired American football players, you seem, the majority of whom seem to gain a lot of weight once they play professional sports. The effects seem to disappear. But actually, these are, we can spend all day talking about these. But also, we need to consider the benefit of sports, and this is something that I really always keen to emphasize. The benefits of sports are great, and obviously, sport is one of the best way to prevent dementia that we know of, having an active lifestyle. So in a way, wouldn't it be wonderful to have all the benefit of sports without the harm of concussion, perhaps? But clearly, maybe all these arguments shouldn't really put people off playing sports, and particularly young people playing sports, because actually then potentially we would have a lot to lose in terms of, you know, the societal benefit, the health benefit of sports, the psychological benefit of sports. So just briefly, what is the emergence? I mean, in the UK and certainly in many parts of the world, one of the most talks about studies in the last couple of years has been the field study that's come out of Glasgow, where they looked at retired Scottish professional football players compared to controls matched for year of birth and postcodes. And they found that, well, perhaps not surprising, this has been found in other studies, the hazard ratio for mortality was actually lower in retired football players, so they live longer than the rest of the controls, on average about 3 years longer in the study, but they had a higher risk of neurodegeneration. And if you look at the causes of death, you know, they were about 20% less likely to die of ischemic heart disease, about half likely to die of lung cancer, but 4 times more likely in the study to die of a neurodegenerative disease. This is from death certificates, so there's a little bit of imprecision here, but on the main, this is a very large study. And also another interesting finding is that goalkeepers were not more or less likely to die from dementia, but they were less likely to have been prescribed anti-Alzheimer's drug before death, which again is an indication that maybe outfield players who are more exposed to certain possible causes like heading the ball may be more at risk of degeneration. So following this study, there's been a lot of talk in the UK, and this has first led to the banning of heading in young football players in Scotland, which has now been extended to England and Wales. So there's been action following this study, and people still don't know what were the causes of the increased risk of degeneration, but it's been attributed in footballers not so much to concussion but to heading the ball. Now, whether it is right or wrong, we could have a discussion about this, but this is what at least one of the conclusions, that in the absence of evidence, something had to be done, and this was banning heading the ball in young football players. There are other points to consider. For example, and this is from other studies, not just in sport concussion, but including severe TBI, suggest that you're not necessarily more likely to develop dementia if you have a severe TBI, but you may develop it 2-3 years later than you would have done. So it seems to accelerate the onset of dementia, but not necessarily make you more likely to get dementia. This is for people that suffer a severe traumatic brain injury. So one of the arguments, well, how come that severe TBI is different from repeat and mild TBI? Theoretically, that may all be similar, but some studies, there's a bit of variance between these studies. Other studies don't actually show any increased risk of cognitive and mental health issues in retired athletes, and there are a couple of studies that are about to come out from, and I can't say much more than this, but it's not from our group, but from North America, showing that actually in retired rugby players and other disciplines, they haven't really found the evidence for cognitive and mental health issues in retired players, and there is also no evidence that severe TBI causes acceleration of cognitive decline in normal aging, or there's no evidence once you get dementia you actually go down more quickly. So what it seems to do is just bring the onset of dementia 2-3 years earlier, but actually don't decline at a faster rate, and during normal life, you don't decline at a faster rate either. Also, one thing that puzzles a lot of people is that if there is a neurobiological mechanism, what is it? Because Alzheimer's is different from vascular dementia, and is different from Lewy body dementia, and is different from frontotemporal dementia. These all have different, have some pathanatomical correlations, but actually they're different pathological entities together. So how is it possible that TBI causes all of these if there is a common thread? So maybe it is that TBI contributes to reduce your cognitive reserve. So the manifestation of dementia may happen at a slightly earlier age, but if you were going to develop dementia, you may develop it anyway. the other question that's really important to ask, is this professional athletes or is it everybody else? And the implications are very significant, because here we're talking about the risk for, you know, retired Scottish football players, American football players, and other disciplines. But is this everyone? And because if it is everyone, we need to do certain things. If this is something that really pertains to professional athletes, then it obviously is still vitally important to find out. But the message is very different to youth participants, for example, you know, about heading the ball or participating in sport and other things. So it really, this is a very important question, and there are some studies underway to try and establish that. Also, are they, you know, sort of, are we talking about concussion? Are we talking about subconcussive injuries like heading the ball, for example? And also, it's important to remember that dementia is not caused by one factor. Dementia is not pathology that's caused by one thing. It is a combination of genetic factors, lifestyle factors, environmental factors. So there isn't one cause of dementia. So it's, you know, in terms of the message that we put out to people is often, you know, is not, well, okay, you may hit your head a few times, but there are other things that you can do to offset the risk. You know, one of them is actually probably to remain active in life and, you know, to continue to play sport, even if it's not a contact sport, but, you know, sort of things like, you know, keeping an eye on your blood pressure, your diet, and avoiding smoking and other things. So this is this in a way all leads up to how we manage concussion, and I think how we manage concussion is that, you know, ultimately we all have responsibility for mitigating risks and reducing the risk of harm to people, whether it's in the here and now or in 20, 40 years time, which we still don't know about. And the number of, you know, each country will have their own guidance, but in particular, each sport seems to have its own guidance, which is not necessarily a good thing. But certainly there are places where guidance is available, how to manage concussion. But broadly speaking, authorities tend to refer to what happens in big consensus meetings. One of them is what is the concussion consensus meeting. It takes place every 4 years. Last year, consensus meeting was cancelled due to COVID, and John is very active in this group on writing guidance and really establishing you know, the evidence for what needs to be, or what is sort of underpins the guidance. But if you look at what came out of Berlin, which was the last meeting we had, it was actually 11 points, all beginning with R, coincidentally. But at the top of the list is recognize and remove, and this is really it's going to lead us nicely into why we've actually done the study that we're going to talk about today. So the recognize and remove are two major challenges. You know, recognizing concussion in sports is not as easy as it sounds. It's probably, you know, without recognizing when someone has been concussed, you really can't really move on to any other R's on that list. So first of all, it's really to recognize the symptoms of concussion when one has occurred. And actually, but if you look at that list, you know, just headache, pressure in the head, neck pain, blurred vision, this could come from another number of reasons. These are not very specific. And most players, professional players that play a match may be complaining of, you know, one or two of these naturally anyway, whether it's, you know, emotional, somatic, or sleep disturbance, particularly after a big match. So in a way, we all recognize these are helpful, but not terribly specific. So the rest of that, say, if you're able to identify the concussion, then you can move to the other R's, you know, rest, rehabilitation, refer, recover, and all the rest. And this is an important distinction that I'm going to come up to next, which is what you do once you've actually recognized that a player is being concussed. And actually, again, there's guidance around this, but effectively, what you do with that player. Well, if you know the player's been concussed, you should remove them from the game, and they shouldn't be allowed to return on the day of the match. But then really, what the study was trying to address is what you do with the player afterwards. Clearly, if you know that the player wasn't concussed, they can return to training the following day, and they should return to training the following day, because it's important for them. It's important for their fitness, is important for the mental health, is important for the psychological well-being of the player. But clearly, if you know they're being concussed, then they should really undergo a graduated return to play. And this is a structured process in most sports have actually adopted the guidance, starting with perhaps a brief period of rest, but now limited period of rest, and then a gradual return to sports through an increase in activity, and then non-contact training, and then contact training. Obviously, it is important that players follow this. And this is different between professional players in an enhanced care setting and non-professional players and young players, but clearly there is a structured process. So missing a concussion is not without penalty for a number of reasons. Obviously, they can miss out on these GRTP, the gradual return to play, targeted treatment, but also there is a risk of being exposed to more injuries before they've actually fully recovered. And then we know the presentation can be more severe. There's some disability, which is not necessarily death on the pitch, as I said before, but people that have suffered multiple concussion can develop chronic headaches, and there's a risk of cognitive decline, which again may not be people going demented necessarily, but some having an impact on our ability to continue to study or work in a certain occupation. And also players that play with symptoms tend to have more prolonged recovery. The performance for the team may be suboptimal, which means that they could affect their season. It could affect the team's performance. So all these obviously have to factored in. They're also more likely to sustain an injury, which is not necessarily a concussion, but even a musculoskeletal injury. And these are studies from, for example, the top one is from the Rugby Football Union, showing that players that suffer a concussion, they're definitely more at risk of suffering a musculoskeletal injury. After about 2 months, the risk seems to kind of return to normal in terms of probability. But certainly there's a period of time where players who suffer a concussion are more at risk of a musculoskeletal injury. And the same study was done by UEFA, and they actually show that players that are professional football players were 50% more likely to suffer a musculoskeletal injury in the season following a concussion than other players. So again, these are important factors for a player to consider. It's not just a risk to your brain, but it's a risk that your season may be compromised just as a result of not identifying a concussion and dealing with it properly. So this really brings us to identifying a concussion and what can we do to improve that. Well, the concussion is often said is one of the most difficult diagnoses to make in medicine. There is nothing that has come on the market that is being validated as an objective tool. It's a single event, but it takes many different forms. It's not just one pathology, and it can be very subtle, but particularly for a doctor in the dugouts, it could be 40, 50 meters away from where a concussion occurs. It's so easy to miss. Get a player at the bottom of the scrum, or an injury happens, near the corner flag. It's just really, really tricky to see. And Patrick will be able to corroborate this. But it's also something that sometimes catches you out, because you go and see a player and the player looks normal, but then pathology really evolves over hours, sometimes 1 or 2 days. So the player may be completely fine to begin with, and the symptoms then develop, a bit later on. So the tool that most people would use is in professional sports is a SCAT5, which was sort of refined, so the version of the SCAT that was refined in Berlin. I understand there's got to be a SCAT6 for the next meeting, but it effectively is a concussion recognition tool. But the problem with it is actually based on symptoms reporting, and it's based on some on the spot psychological testing that have sort of limited sensitivity and specificity. And just to show perhaps the limitations of this is an example from rugby, where rugby has a professional assessment of concussion, which is based on the SCAT5, but also video replay. So the video feeds are made available to doctors in the Premiership, which in theory should make it really hard to miss a concussion. And this is so this is probably one of the most rugby players you know of is George North, at the time playing for Saints. So if you look at the incident, this is a doctor assessing George North immediately after the event. If you look at the footage from BT Sport, you can actually see there's a dent on the pitch, so it's actually quite hard to miss, you know, the fact that George North hit his head, and he actually was motionless for a few seconds. But by the time the doctor ran on the pitch, he was able to answer all the Maddox questions correctly. He looked completely orientated. He was taken off. He was assessed according to the head injury assessment protocol, which he passed with flying colours, and he returned to the pitch. Now, this footage wasn't really available to the doctor on the day, and the other footage actually I was able to see didn't actually show the full picture. So there was a lot of controversy and some furor around this injury because George also suffered a few concussions in the past. But just to say, even with the best technology, people in the TV room, the best qualified doctors in the game in England, and all the modern tools, it's still possible to miss a concussion like this. So what I really like to introduce is the fact that, you know, for example, rugby is very advanced in terms of you know, head injury recognition and management. And what rugby uses is a tool called the head injury assessment tool, which is based on three parts. Immediately, so in a case like that, a player is removed, is taken to a medical room, it is assessed over 10 minutes with effectively a neurocognitive test, the test of balance and neurological examination, then the test is repeated after the match and then after 2 sleeps. But most sports would actually simply have the first part of this, where the doctor is assessed on the pitch or in the medical room immediately without the repeat assessments. And actually, in community sports, maybe not even that, but so it's based on a SCAT5. And if you look at the performance of the test, it does actually have an accuracy of about 80%. Now, this is based on the doctor making an assessment of the test or the HIA, but if you, strictly speaking, you should be comparing the performance on the HIA with the prior baselines. When you do that, the performance of the test is even worse. It's only 0.6% actually, it's only sort of 60% accurate. If you use normative threshold, it's a little bit better. But 60% means it's not much better than tossing a coin. You know, if you use the HIA1, so the screening that you can do in a medical room or on the pitch. And if you look at the individual components of that, so the Maddox questions, you know, do you know where you are? Do you know you were playing? Do you know the score? Do you know the score last week? So these are the questions that a doctor would ask on the pitch when they go and rush up to see a player. And if you look at this in a logistic regression model, the Maddox question actually don't really add anything at all to the diagnostic power of this tool. It's really what matters are reporting of symptoms and clinical signs. So this immediately tells you that two things: that one, you need the player's cooperation to report symptoms, and two, you need someone to be able to elicit clinical signs, so a doctor or a physiotherapist or another trained practitioner. If you look at for example, the diagnostic accuracy of the Maddox questions, you see that the sensitivity is only 8%, so really, really poor. And actually, the specificity is high. So if you fail your Maddox question, yeah, you are concussed, but you're going to miss a lot of players if you just ask the Maddox questions. You know, 90% plus will be missed. And the error in the curve is 0.5, which again, you might as well flip a coin and decide if the player is concussed or not. Symptoms are definitely more sensitive, but still about 50% sensitive. And the other component is if you don't do a neurocognitive test, it's clinical signs. But again, that's not particularly sensitive either. They're specific. So if you fail it, you're positive, but there's a chance you're going to be missed on these assessments. So what can we do to refine these diagnostic tools? We really need to do something to improve the accuracy of these assessments that are done, you know, immediately after an injury. And there's a lot of interest in concussion biomarkers and TBI biomarkers, and a lot of these have come from the protein field. So, you know, effectively in protein biomarker biology, we look for something that may have come from a damaged cell that is released into the bloodstream. and then it's picked up by an assay. And people have been looking for various different types of proteins that may be released by neurons or glia or other supportive structures, and with varying degrees of success, and in terms of predictability, specificity, and accuracy. But it's probably fair to say that protein research has been a little bit disappointing, and our group ourselves have been doing it for nearly 20 years, and actually we're still doing it. But there is, as I say, there are several limitations to that, including the fact that actually there isn't an awful lot of cell death after concussion in sport, which is a good thing. So that there's very little cell damage. And also you have the blood-brain barrier that prevents these molecules from appearing in the bloodstream. So for a few years, I've been interested in something a little bit different, which is genetic signals that cells send to each other in response to an injury. So this is a big field, and primarily in oncology, but now I think emerging in other conditions as well, including injuries of any kind, traumatic injuries, for example, myocardial infarction, liver injury, just to name a few. So what are these compounds? They're mainly known as microRNAs or small coding RNAs. And these are released by cells that want to effectively reprogram other cells. So the genetic messengers that cells exchange to say, well, this has happened, and now you need to switch off genes that are not necessary and switch on genes that you need for repair or change in metabolism or other response mechanisms. So these are becoming much better studied in recent years. I mean, it's just ballooning the number of studies that are on microRNA. So there's genetic signals that in response to injury, in this particular case, the cell release, and they're released in every tissue, not just in the brain. So the body effectively reprograms this stuff. So these are traveling microvesicles in the bloodstream, but they're also present in saliva, they're present in tear fluid, they're present in all organs. So they, following a stimulus, they just released, and they just get then taken up by target cells. So they move in out of cells. What we didn't know prior to the study is actually how quickly this response was, and we will come to that. So the problem with the problem of timeliness is a problem in unconscious that probably taking a lot of time, but the problem of timeliness is a problem in many studies. For example, there's a lot of interest in protein biomarkers, and often these are released over a period of hours. And actually what we worked out in our research, they're not just released, they're synthesized de novo following injury. So it's going to take a lot of time for those proteins to appear in the bloodstream. But also the problem with a lot of proteins that when you look at people that have had other injuries, actually, they may be very good for traumatic brain injury, except for timeliness. But when you look at their specificity, they also release following, for example, orthopedic trauma. So they may not be particularly useful in people that play certain sports. They may not be used in road traffic accidents or other conditions where you may have more than one injury. So years ago, we started looking at microRNAs. First, we looked in blood. We did a study called the Golden Hour study, that's where the blood was taken by the paramedics at the roadside, and it was taken within 15 minutes of injury and then taken again in hospital. And what we found is that there were lots of microRNAs in blood that actually gave a very, very accurate reading of a mild traumatic brain injury, with nearly sort of 100% accuracy. The problem with that, obviously, is it's impossible to do a blood biomarker. Well, it's impossible. Other people are doing it, but it's really difficult to do a blood biomarker study in professional sports. You just don't get the samples, and you just don't have the. So you have a very big problem with sample selection and in the practice there was convenient samples. So the results may not be that accurate, and the results may not be generalizable. So. A few years ago, we started looking at, well, okay, we found them in blood, but can we find them in other fluids? So we started looking at saliva. And saliva is absolutely rich of microRNAs for reasons that we don't entirely understand, but there were more microRNAs in saliva than any other biofluids. But saliva has an important role in as an antibacterial agent, but particularly in the crosstalk between our friendly guests, the gut microbiome. We have more microbial cells in our body than actually our own cells, and they're very important for metabolism, brain metabolism, and so forth. So we thought, is this something we could look at in saliva? And saliva has been used, for liquid biopsies for many other conditions, actually, oncology and other diseases. So saliva is obviously very, very easy to get, and it's full of microRNAs. And a few years ago, we started looking at some people that come to the concussion clinic to see whether we could identify microRNAs, and we were very encouraged by the early results. And that's, we could see that there were several microRNAs that were different between the controls and the people that suffered a recent concussion. This is sort of leading to what Patrick is going to talk about next. But just to say that there's a lot of research that still needs to be done. But some of the research we're actually doing here in Birmingham, some of the research we're doing in the UK. But there's a lot more research that needs to be done, and it's great there's so much interest in concussion research at the moment. So I think what the areas where we're focusing is, genomics, morbidities, subconcussive interest, heading the ball. Our group has a very strong interest in biomarkers and diagnostic modalities, and there's a whole field of research for epidemiology. Big studies are underway, longitudinal and mechanistic, to trying to unravel the question of neurodegeneration and CTE. So one of obviously the studies that we do on biomarkers is a study that John has kindly introduced, which is we thought, okay, where can we study whether salivary microRNAs actually are of any value or not. Since this is where we partnered with the rugby football unit to do the microRNAs for evaluation in concussion and professional rugby football and cricket study, so the SCRUM study. So I'm just going to stop here. I just want to thank a number of people that actually helped us with the research, even at this stage. There's a long list there, but I hope you're all primed and excited to listen to what Patrick has to say next, because he's going to get to the meat of the SCRUM study. And for those who do not suffer from insomnia and didn't see a need to read the study, Patrick is going to tell you all you need to know. Thank you for listening.
Thank you, Tony. I think while Patrick switches over there, his presentation, just to thank you for setting the scene so well. Really a lovely synopsis of where we've come from and where we are with sport-related concussion, and a great introduction into microRNAs and exactly why they may be the new frontier in terms of diagnosis, particularly in the saliva. So we're looking forward now to recent PhD graduate, Dr. Patrick O'Halloran, to tell us what his research has shown on this and what its clinical applicability is in the terms of sport-related concussion. So over to you, Patrick.
Brilliant, thank you, John. So obviously Prof Patricios and Prof Belli have teed me up really nicely. So it only remains for me to say before I start, just to explain that Marker is a University of Birmingham spin-out company formed to make sure that this academic work translates across into a test that can be brought to sport and community sport commercially. So I should explain that Professor Belli is a founder and shareholder of that company, and I am an employee of that company. So put simply, the SCRUM study that we'll be talking about now was an attempt to identify diagnostic biomarkers of concussion in the saliva of male professional rugby players. And we did that in the top 2 tiers of English Rugby Union. And as you can probably guess, the study was investigating the role of salivary microRNAs for that purpose. Now, we're familiar with the context and the diagnostic challenge of sports concussion, but microRNAs might be a more recent kind of avenue for investigating this. So I think it's helpful just to reinforce the point that, put simply, if we think about DNA as holding the code for a protein to be produced and messenger RNA as the intermediary en route to getting a functional protein as the end product, microRNAs get involved in inhibiting that process by targeting a specific messenger RNA. So microRNAs are cell-to-cell signaling molecules. As the name suggests, they're very short sequences of RNA, and they're transcribed and mature in the nucleus and the cytoplasm of cells, where they join with these multi-protein complexes to form these things called RNA-induced silencing complexes. So that's a microRNA specific complex, which will then produce its effect by inhibiting the translation of its target messenger RNA. So in this way, they have this role in kind of really fine tuning gene expression. There are several thousand known microRNAs, and a single microRNA can have multiple different targets. And likewise, the expression of a single gene can be affected by multiple different microRNAs. So it's not a blunt tool, it's a really fine balance. And it allows for the fine tuning of gene expression across a whole range of processes. So in the brain, for example, microRNAs have roles in synaptic formation, in long-term potentiation, the formation of beta amyloid. The dysregulation of microRNA expression has been implicated in neurodegenerative disease and psychiatric illness. So they're really interesting. But in terms of biomarkers of concussion, what all of this means is that we're looking for a signal that looks more like a signature of change in the expression of a range of microRNAs, rather than something as simple as you might expect to say, a protein biomarker where a level just goes up and then comes down. The other thing that's important about them is that they're packaged in these extracellular vesicles, as Prof Belli's video was showing, and that protects them and allows them to move between body fluid compartments, so across the blood-brain barrier, so they can appear and be measured in saliva. So the study of these microRNAs is a really rapidly expanding field. It's not just us that's doing it. There are several other groups who are looking at this in different forms of brain injury and demonstrating that usually a panel of microRNAs can be used to form a sort of diagnostic or a prognostic signature. So the SCRUM study sought to test whether a diagnostic signature could be identified in elite male rugby union players. And we did that by trying to collect samples of saliva alongside the World Rugby Head Injury Assessment process at time points 1, 2, and 3 between 2017 and 2020. So you'll see this is a kind of summary slide of our protocol. We baselined all of the players before the season began, so we got them all before injury. And then for each player entering the HIA process, they give a sample at 3 time points, regardless of the outcome. And then for those of you kind of familiar with the HIA process, you know, all players go through the HIA 1, 2, and 3, and it's only at that point that it'll be decided whether they're a concussion or not, whether concussion's been ruled out. In addition, we collected from 2 categories of controls. So uninjured controls who just played a match, hadn't been assessed, you know, for concussion because no one had any suspicions, and musculoskeletal injury controls, so players who had played a match and had extracranial injuries. We used the outcome of the HIA process at HIA 3 as our gold standard. And that was then independently verified by 2 RFU doctors, sort of separate to any of the teams. So it's kind of like a gold-coated gold standard. And that gave us a kind of situation where we're comparing our biomarkers to the HIA as our reference standard. So at this stage, we can't be correct and the HIA incorrect. You know, that's not a situation that can happen. But this was one of the strengths of our design, because it meant that we were able to get samples from people who had been rigorously assessed and diagnosed with concussion, and people who'd been rigorously assessed and concussion had been ruled out. And that's really important and rare. Often biomarker studies will compare between confirmed concussed and uninjured participants, or at best confirmed concussed and uninjured participants who had also undergone a SCAT. But the SCRUM study design reflects the situation in which you would actually use this test. So initially, you thought all of these people could be concussed, and it tells you the difference between the ones where it was decided they were and the ones where it was decided they weren't. I don't know if anyone can see my speaker view, but I'm using my hands a lot, just for reference. So this is a diagram taken from the study paper published last week in the BJSM, and it summarizes that we recruited just over 1,000 players, and we eventually ended up working with samples from 120 HIAs in which the diagnosis was concussion, 53 in which the diagnosis was concussion has been ruled out. We had 102 uninjured control players who'd just taken part in healthy match participation, and 66 musculoskeletal injury control participants who had had an extracranial injury. And overall, our study compliance across the whole 2 seasons we were working was 56%, which is pretty good compared to other kind of similar studies. And we learned a lot. You know, it's a good conversation to have over a beer. We learned a lot about working with clubs and getting good compliance and how to kind of work in this setting. So once we had that material collected, we went through 3 phases. The first phase was a process called next generation sequencing. So this is a high throughput technique which basically gives you a library of all of the small RNA species in a sample. So importantly, that's not just small RNA species that have been described previously, but also brand new ones that nobody's ever discovered before. And that's a real strength in our study. But unfortunately, the process is expensive. So we did that in a small subset of the initial samples to generate a list of the most promising candidate biomarkers. These best candidates were then measured in all of the samples collected in the first season of data collection. And this was used as the training set on which statistical modeling was performed to try and identify the combinations of biomarkers that would accurately identify the HIA confirmed concussion group. When the second season of data collection was completed, this model was then tested in the samples collected from that second season. And again, this is a strength in the design, because common to all sort of large data set work, so metabolomics or proteomics, where you've got lots of potential markers, there's the potential for overfitting, where too many variables are included in the model and it can't be replicated. So sometimes it's not a concept that's widely talked about, but basically, if you imagine, if you gave me unlimited information about every player's age and birthday and what color boots they wear and what color car they arrived at the ground in, you could make a model that would just be random from that information that would diagnose concussion. But because it's nonsense, you wouldn't be able to replicate it. So one of the real strengths in our design was that we were able to then go on and validate, test our model in a second season to validate it. And this is the work that we've published and presented in the SCRUM paper that lays out basically a panel of 14 microRNAs and small non-coding RNAs is kind of the catch-all term for, as you'd think, all small RNA species. So a panel of 14 of these markers can be used to identify concussed athletes with a high degree of accuracy, so an area under the curve of 0.94. This then is another diagram taken from the SCRUM paper, which sort of demonstrates the ROC curve analysis that we conducted over season 1 and season 2. So season 1, the training set at HIA1, HIA2, and HIA3. So that's T1, T2, and T3. And then in the second season, our sort of our testing set at HIA2 and HIA3. Now, you'll see here all of the comparisons made are to the HIA confirmed concussion group. So you can see there we've got an HIA negative sort of comparison. You can see the accuracy, the area under the curve there. Now, it's interesting to note that top left panel, the area under the curve at the HIA1 setting, time point, looks really, really exciting. It's 1, so that's really exciting. But this is the setting where we have the least data, because we modified the protocol for the second season to drop this HIA1 sampling point in order to try and maximize our compliance, because the feedback was it was taking a bit of time to collect that. Subsequently, we changed our collection device completely to a swab rather than a pot that the athlete has to spit into. And so I think that we would definitely be able to bring that back in. It would be much kind of slicker to look at that further. So what are the implications of these findings, for rugby? But of course, this does apply more widely to sport, generally. So at the elite level, A test like this offers the opportunity to support a decision made using the HIA system to confirm or refute a diagnosis of concussion. So the HIA and all of the SCAT and those tools that we've talked about are a measure which uses clinical symptoms to identify features consistent with concussion. And this test offers the opportunity to measure signals of traumatic brain injury pathophysiology and incorporate that into the decision making. So this has the potential to support the decision-making of medical staff, but also to give players greater confidence in the outcome of the concussion diagnosis process and reassurance. And it's been really interesting getting feedback from players about how this might change their reporting behavior if they feel like there's this degree of objectivity or biological objectivity in the standard. In addition, there's the potential, with one eye on the litigation rumbling in England around rugby, there's the potential for medics and organisations to use this as part of the management of their potential legal liability. At the community level, a test like this offers the opportunity to significantly improve concussion detection over the current standard of care, the recognise and remove criteria. So it offers you the chance to replicate the accuracy of a clinical assessment where maybe a healthcare professional isn't available, and potentially in situations where even a healthcare professional is available, you don't have the infrastructure of multiple video angles, etc., etc. So it may improve the accuracy in that situation also. In addition, though, further work in this direction has the potential to provide two sort of novel, significant improvements in the care of concussed rugby players. So the first is in the management of recovery. So predicting and managing and monitoring recovery is difficult, and it requires players to be very accurate and very honest in their self-reporting. Although we don't have enough data to kind of understand this at the moment, we suspect that this might be a useful measure to track back to normal in terms of guiding return to play. Likewise, in terms of the long-term monitoring, work that we've done so far demonstrated that in a group of 200 or so players who provided baselines one season apart, the salivary expression of several markers which other basic science work has linked to neurodegenerative pathology change over that interval, and importantly, change more in players who suffered one or more concussions. So though that's still at a very early stage, it hints towards maybe a method of monitoring cumulative head injury exposure and contributing to the management of player brain health long term, that again would be a big step forward for player welfare. So we were really pleased to have gotten a very positive response in the press to our study publication last week. It's really, really great to have people talking about this, but we're conscious that the most important thing now is to take our next steps to maximize the potential positive impact we can have on player welfare with this work. And so this is what those next steps look like. So in the setting of elite male athletes, we need to undertake some further collection and development so that we can answer questions about recovery and return to play. And as we've said, these are questions that players' feedback suggests are really important to them. Being able to tell them when they've recovered and taking away some of the other pressures on that decision making would be really valuable. We also want to understand how it integrates with the HIA and get feedback from clinicians on, how can we present results and use it optimally. So that's really important. And we think that we will be able to do that with a further season of data collection in 2 elite men's competitions. In the context of junior and community athletes, we need to try and replicate this work that we've done here. And at this stage, Prof Patricios is working on a study in junior athletes in particular that's going to get us an answer on that, which is really exciting. In the setting of female athletes, we have collected a small amount of data so far from the women's Premier Rugby competition in England, which is semi-professional level. And the limited work we've been able to do so far suggests that men and women are different in their salivary expression, male and female athletes. But we need to try and find women's competitions that are running an HIA process to really drill down and understand that and develop a test that works in female athletes. And finally, there's the question of how this might be used in long-term monitoring, something which would be really good to embed in any of the future work that we do. So in particular, then we're keen at this stage to keep the momentum going, and we're hoping that we can work with World Rugby to identify people who are interested in helping us do this work in women and in elite men. Thank you very much for your attention, for your invitation to speak, and in particular, in addition to all of Prof Belli's thank yous, I'd like to thank all of the players and the medics who provided their time and collected samples, because we were asking club medics to do this themselves, so it was no small undertaking on their part, and we're super grateful to them for that, and also to the RFU and the Premiership for their fantastic support. So our contact details are on there, and happy to throw over to the Q&A.
Absolutely superb summary of very, very complex research there, Patrick. Thank you very, very much to you and Tony. So I think, as with all good presentations, we've got a number of questions which have arisen. Can I ask you to just unshare your screen for us, and then we can see you as we ask you some of these questions. And some of them have come up here on the Q&A, and some have been texted through to me, so I'll try and coordinate them all, and feel free to jump in. So the first question, we'll combine a couple of them to say, you know, where did the thought process come of looking in saliva for these biomarkers? And I suppose a step before that, how do they get into the saliva? You mentioned they're able to cross the blood-brain barrier, etc. But just some of the biology behind that, if you can explain that a little.
So this is a really, really good question, because microRNA biology is actually a relatively new field, and until probably about 10, maybe 15 years ago, microRNAs were thought to be cellular debris, so just a bit of floating, bit of genetic material in the bloodstream. But actually, then the interest started from the field of oncology primarily, where people realized that actually these have a particular function as messengers. Now, why they're particularly abundant in saliva, we don't really know. But actually, they say that they're 3-4 times more concentrated in saliva than in blood. And also, in terms of number of species, they're more abundant in saliva than anywhere. The other place is seminal fluid, and that probably have a function in terms of is epigenetic control and everything. So we know that sort of they are messengers. Now, where they come from is actually this is the beauty of this, and that microRNAs are already present in tissues. They don't need to travel from very far. So they're actually present already in cells, in salivary glands. And now what we don't understand is what stimulus travels from the brain to the salivary tissue, effectively, to release the microRNAs. So we don't understand, but we know there's a potentially, and this is the thing that we'd be looking at, is probably through the vagus nerve, because the vagus nerve has got certainly many functions in response to head injury. It has its function on the control of systemic inflammation, and it has a function on the immediate sort of autonomic response to injury. So possibly that stimulus is quite quick because it comes from a neurological injury, because the fact that these were present minutes after the injury is intriguing. We also know that microRNAs in blood from the golden hour study change very quickly in response to injury. So maybe the snooker ball effect, you get something from the brain to blood and to saliva. But the fact that these are detectable very quickly means they probably don't have to travel all the way out of the brain into the bloodstream and into saliva. They're probably, and when we look at the microRNAs that are present in the brain after injury from other studies in humans, and the blood RNA in saliva and the blood RNA in blood, actually there are very few in common. So these are microRNAs that constitutively present in saliva. They get mobilized as messengers. Their function, as I say, Patrick has already alluded to this. They have many roles. They have a role in body metabolism. They have a role in the crosstalk with the gut microbiome, and they possibly have sort of some of these are linked to they're very specific to neuronal responses to as I say, long-term degeneration, depression, potentiation, and all the rest. So I think it's a new field. So you have to bear with us if we don't have all the answers, because we haven't got that yet in terms of science, but probably the only thing to say is that microRNAs have become, salivary microRNAs in particular, become a target for liquid biopsies for a number of conditions. So we're not the only group that's actually looking at salivary microRNAs. It's just an easy place to get microRNAs, and they change in response to a number of different stimuli and different pathologies in the body.
I think a kind of interesting idea that I've come across recently is related to this exosome carriage. So exosomes contain, they're one method of transporting microRNAs from place to place, and they're very richly packed into areas where there are synapses. So one of the major stimuli for their kind of release, their indiscriminate release, is stimulation of glutamate receptors and calcium influx into cells. And when we think about, neurotrauma physiology, those are kind of, bedrock processes in terms of what's going on. So possibly what we're seeing, and it may be that what we're seeing at the early time point is an effect of that kind of depolarization, glutamate spreading depression. And then subsequently down the line, perhaps we're seeing, just like we see exercise intolerance because of imbalance with the autonomic nervous system, the salivary glands are really richly innervated by the autonomic nervous system. So potentially we're kind of seeing one process, an immediate process that happens because of depolarization, which would make sense because it's quick. And then down the line, we're seeing more of a dysregulation because of that upset in innervation. It's one of those where, watch this space, and as soon as we know, you'll know.
Great. Patrick, you spoke about the selection process for the sort of package of mRNAs and the next generation sequencing process, which you explained eloquently. And then you said that the way the selection was made, you looked at obviously those that were too generalized and weren't specific enough. You had those that sort of met the sweet spot. And then you spoke about those which were a little bit of an overfit or too good to be true. Can you just explain that? Because to me, in my mind, those would be the ideal if they were that specific. How did you actually select those, that sort of group of mRNAs that you felt were most appropriate for traumatic brain injury?
So the overfitting idea is less in terms of the specific microRNAs themselves and kind of what we know about them, although obviously we had one eye on what other groups had found and described, and we made sure that we thought about those for inclusion in what we were looking at. The overfitting is more in terms of making your model too complex. So if you kind of cherry pick, okay, we're going to have 56 microRNAs in our model, then you get an area under the curve of 1. But then when you try and do it again, you just can't. So that was the, because it's not biologically plausible. Now, the interesting thing is from a very early stage, we were having conversations to kind of say, we should be okay with our model not being 100% in terms of the area under the curve. Because if it's 100%, it suggests that the HIA is perfect. And we know that it's not. There's potentially going to be situations where the HIA misclassifies people, and we may have to think in terms of a biologically significant concussion and a biologically not significant concussion, maybe in the future, as sort of biomarker technology takes off. But yeah, so in terms of the overfitting, it was more like the total complexity of the model rather than the specifics of the markers that we put in.
Now, in terms of how we can apply these markers, obviously diagnosis is key. What about severity of injury, and what about monitoring recovery? Is there a role for these biomarkers in those situations as well?
So both of those are situations that we really want to have a look at. Unfortunately, in terms of severity, we didn't get the data capture of the clinical data capture good enough to be able to say that. So, are we seeing a different pattern in people who have category 1, immediate removal signs as compared to people who develop symptoms at 24 hours after the match? So that's one of the key questions that we want to try and drill down on in our next collection. In terms of the recovery, again, we were able to collect some data, but the compliance with it was the area where we really dropped off in the studies that we've done so far. So it's almost like, we really, really need to be hot on that and making sure that we're getting not only the clinical information, but also the follow-up of the marker measurements down the track to answer that. But I feel like, there's going to be a role for this in terms of tracking it back down.
How soon after injury are the mRNAs expressed in the saliva?
So the earliest time point that we looked at was that HIA1 time point. So although it's difficult to be certain about when the inciting injury occurred, potentially that's as soon as 10, 15 minutes after the injuries happened that we could see that top left panel of a difference between those groups. Then the HIA2 is the end of the match. So again, depending on when the players kind of showered and come in for their HIA2, that's kind of maybe as little as 40 minutes after the game, maybe as much as an hour and a bit after the game they've come in.
Okay. And then quite a lot of questions coming in around the sort of commercialization of the product. So if we look at it, firstly, the turnaround time for testing. Secondly, what's this test likely to cost as a ballpark figure? Let's just start with those two, the turnaround time for the test and the actual cost.
Yeah, so in terms of the turnaround time, we've had lots of questions on that. And so this is, in terms of what we have at this stage, it's a lab-based test. So you take your swab, you mail it off to a laboratory, the test gets run. And so you're looking at getting a result back, in about 24 hours. So if we're thinking about kind of the UK, if we get a sample sent down from Edinburgh, it's like a 24-hour turnaround time. If we get a sample sent from the university, from Birmingham, then obviously we can do it quicker, but that's a rough kind of ballpark. So you'd have it you'd send it the end of the match, you'd have it the next day. So thinking about whether that player can be cleared to go back into training or whether that player is going to be doing a mandatory stand down, you'd have that result sort of within 24 hours of the game finishing. In terms of the question of cost, that's one where we haven't fully got to the bottom of that yet. But what we would say is that we're using similar technology to what's being used for COVID testing. So as we'll kind of be tracking the cost of that effectively as the cost of those consumables comes down and changes, and so will ours. So it's around about that area.
Great. And then some other questions coming in around other uses for microRNA, and Digby Allman-Brown, one of our neuropsychologists, speaking about its role in HIV infection, and whether there's some overlap there in terms of microRNA expression and degree of cognitive impairment. I mean, is there a role in its use there?
That's a really good question. And so the honest answer is at this stage, we don't know. We have a study running with retired athletes who are being neurocognitively tested that may shed some light on that. And in light of the findings that we had around the repeated baseline of our current players, I'm really keen to try and get hold of their annual neurocognitive testing data and just see if there are any patterns there to help guide us for another study to look at that in more detail. So at the moment, we're really not sure, but that's something we would really, really like to look at. In terms of other oh, sorry, Tony, you wanted to say something? No,
I'm just saying, just in that vein of cognitive decline, I think there are some studies suggesting they've got quite a, sort of an interesting body of literature now suggesting that a role for not necessarily saliva, this is blood microRNAs in dementia, and potentially these being very early markers of dementia. Some studies are suggesting there's quite a convergence of literature on just a few of these that may be, but obviously in dementia is difficult to be specific, because every people have alluded to the fact, sort of inflammation playing a role. And obviously if you have symptoms of dementia, maybe you have other comorbid conditions, so it's really difficult to be specific about that. But certainly there seems to be sort of body literature emerging of that, as well as mental health. I mean, people are now reporting, microRNAs for depression, for anxiety, for obsessive compulsive disorders. I mean, these are sort of primarily in blood again. So, and there's also an interesting, so HIV, I've seen some articles on that, the HIV and microRNAs, and people are also interested in microRNAs in long COVID, the long-term effects of COVID. And obviously we don't have any data on that, but just to say, now people are beginning to look at potential uses of microRNAs in other conditions, I say, where cognitive decline may be present.
I'm sorry, I was talking too much with my sport hat on and thinking we were just thinking about players and neurocognitive testing. But the other thing, just to add to that, is that the really cool thing about microRNAs that makes them really a value to look at in saliva is their ability to cross the blood-brain barrier. And why would that be useful? One theory is that that's a way of communication between the brain and the peripheral immune system. So it may be that these things we're seeing are really embedded in inflammation and neuroinflammation.
And then we're going to wrap up soon because that's hour and a half has just flown by. But in terms of the actual measurements, will there be comparisons to a baseline, to a specific player? Do you think that'll be necessary? Or will it be pretty much a universal cutoff based on mass screening that are done as part of these studies?
So we've done some further work on that since the paper was published, and I think having a baseline is definitely useful. And as Patrick alluded to earlier on, I think there are changes from season to season in the levels of these biomarkers. So I think with having a baseline actually refines the prediction, probably not by an awful lot, probably by a few percentage points, but certainly in this particular field, a few percentage points. And obviously, if you can improve accuracy and particularly sensitivity, means keeping more people safe. So having a baseline is definitely helpful, but not essential from what we see. But so yeah,
and it may not justify the cost of doing it on everybody. And then just one last question in terms of controlling the process. Someone asking about the sterility of the mouth, whether that affects the process at all, whether there's bacterial infection in the mouth, does that contaminate the process? And then I know that you controlled both for measurements at rest and measurements just post-exercise and with musculoskeletal injury. And you obviously found that there were significant differences with the traumatic brain injury group. But just a question on sterility of the mouth and whether that affects things at all.
So this is a really good question. And so I can answer in two ways. One is actually that we didn't collect questions on oral hygiene and whatever, but Patrick has made this point very eloquently before. These are professional players that wear mouth guards, and they get quite regular oral checks. But so with this, just a generic assumption. But one thing that was done as part of the NGS, the first filter of the next generation sequencing is to look at all the bacterial RNA and to throw it out. So the first pass of the next generation sequencing was to look just at human. So obviously, there's a lot of things that as I say, some of the NGS looks at things that may have not been discovered yet. But the first pass was to throw out all the bacterial stuff, which actually, we think in retrospect, we went back because actually there's potentially this crosstalk with the bacterial flora in the mouth or in the gut may be really interesting. But what the study looks at was just sort of the human aspect of it.
Well, I think that's a great question to end on and really summarizes the complexity of this process and also the great breakthrough that your group has made. And I think it's accumulation of many, many years of fantastic work. And it's really going to be very exciting to monitor this area of science moving forward. So thank you very much to you both, to Dr. Patrick O'Halloran, to Professor Tony Belli for sharing these ideas hot off the press, for the time you've spent in preparing this presentation. We look forward to ongoing collaboration at Wits University with you, and hopefully we've whet the appetite of a number of clinicians and researchers around South Africa to help this process move forward and really make contact and collision sport a lot safer. So thank you very much. We really appreciate it, and we look forward to monitoring your work going forward. Thank you to everybody for attending. Again, thank you to Robin Saggers for being in the background, and to our sponsors again, Asina Lita, for supporting us through this year. And our next Concussion Interest Group meeting will be on the 26th of May, and we will have that presented by Dr. Catherine Schneider of the University of Calgary, who will talk on her work in terms of prevention and rehabilitation of the concussed athlete. And then Robin has put up a slide about the next talk in the WiSH webinar series, which is looking at exercise, and particular exercise after pregnancy, another field of great interest. So we look forward to you joining us there. The CPD points you can see available at that red cap link, but if you've registered, then we can certainly send you your CPD certificate through the automated WiSH website and process. So thanks very much for your attention. Thanks very much for the enthusiasm and the questions, and for your support of WITS Sport and Health. We look forward to seeing you at the next talk, which will be on the 14th of April, I think, Robin, not 14th of March.
Correct,
So
14th April.
Yeah, so it's the 14th of April. We'll see you then, and have a good evening, everybody. Thanks very much.
Thank you.